Hello, my name is Dr. Roger Henderson and I'm a GP in South West Scotland, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those of us working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, then do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now, in this episode, I'm going to be discussing trigeminal neuralgia, and I'm also going to be discussing this in greater detail on the GPnotebook Study Group 6 meetings, which start on the 19th and the 21st of March. We do hope to see you there, but don't worry if you can't, because these are going to be repeated throughout the year, as all our study group meetings are. So trigeminal neuralgia, or TN as I'm going to call it, because it's an awful lot easier than saying trigeminal neuralgia every time, is a chronic debilitating condition that causes intense and extreme episodes of pain in the face. And unfortunately, there have been recorded episodes of suicide linked to trigeminal neuralgia because of the pain extremities. The episodes are sporadic, sudden, and just last from a few seconds at most to several minutes, and are usually described as like being an electric shock or a burning pain. It's currently classified into three main subgroups: idiopathic, classical, and secondary, based on imaging findings. And MRI brain imaging with trigeminal sequences is therefore usually recommended in the diagnostic workup of trigeminal neuralgia. The unilateral electric painful shock-like pains are abrupt in their onset and abrupt in their termination, but it is unfortunately a highly debilitating disorder that dramatically affects the quality of life in people with it. Women seem to be slightly more commonly affected than men, and it does increase with increasing age. It is unusual and uncommon to see someone with trigeminal neuralgia under the age of 40. Now, the right side of the face, in about 60% of cases, is affected more than the left side. And bilateral, simultaneous TN pain is actually quite rare. In fact, I've never seen it in about 40 years as a doctor. And more often, patients in that situation experiencing side-alternating unilateral paroxysms of pain than both sides of the face being affected exactly at the same time. If we look at the distribution of TN, then the maxillary and the mandibular divisions of the trigeminal nerve are most frequently affected, although in about 1 in 4 people with TN, there is ophthalmic division involvement as well. Now, the frequency and the duration of attacks are highly variable. And although in the majority of people, in about 3/4 of people with TN, the pain lasts less than 2 minutes and often just a few seconds, there is a significant minority that do report attacks lasting up to 10 minutes, which is absolutely dreadful for them. And around 70% of patients, about 2/3 we think, occasionally have a series of paroxysmal attacks that can last up to an hour. And that can cause diagnostic confusion because we're used to TN just being very brief, very short on-off episodes of pain, which is why obtaining a good descriptive history of the frequency and the duration of attacks in short-lasting TN pain conditions can be slightly challenging. The triggers that linked to TN are one of the hallmark clinical features of this problem, and this is usually linked to innocuous, extremely mild stimulation of the face and the intraoral muscles on the side of the pain. And about 99% of patients with TN, virtually all, report triggering of attacks, and these are considered to be absolutely pathognomonic of trigeminal neuralgia. Now, the common ones that we would say here would be things like light touch, chewing, shaving, brushing the teeth, talking, or even a very, very slight blowing of the wind onto someone's face has been known to trigger a TN attack. But most people with TN appear to have several trigger factors. It's important to note that the location of the pain doesn't always concord with the site of the trigger zone, and the usual trigger areas seem to be places like the nasolabial folds, the chin, the cheek, and the lateral part of the lower lip, as well as the upper lip. Now, in the vast majority of cases, the physical and neurological examinations are normal. But in around 1 in 3 people, there can be some sensory changes that are slightly longer lasting, including things like mild hypoesthesia. I've never seen this, but on very rare occasions, if you examine a patient during an actual severe attack of TN, you can see ipsilateral facial muscle contractions. And this is where the term tic douloureux comes from. But as I say, it's really very unusual to actually see that happening in practice. The differential diagnoses can be quite significant and multiple. Now, migraine is obviously one to consider here, as well as giant cell arteritis. But do remember that trigeminal neuralgia rarely affects the forehead alone. Cluster headaches you have to obviously consider here, as well as dental pathology, temporomandibular joint dysfunction, neurological conditions such as multiple sclerosis, and tumours. We do, however, think that the majority of cases of trigeminal neuralgia are linked to pressure on the trigeminal nerve from a venous or an arterial loop. Now, unless there's uncertainty regarding the diagnosis, you don't usually need to have any particular tests done, but if you refer a patient on for specialist review, they would normally go on to have a brain MRI scan. And this is indicated to rule out other potential causes of pain if the diagnosis is uncertain or if red flags are present. And when I'm talking about red flags, I'm thinking of things like an age of onset under the age of 40, if there are any sensory changes or deafness, if there's difficulty achieving pain control with optimal medical management, if you're considering that there may be some skin lesions in the area that you're concerned about, if there's any optic neuritis, or if there's a family history of multiple sclerosis, because obviously we're looking to rule out MS in those cases. So, if we're looking at pharmacological preventive treatments, then carbamazepine and oxcarbazepine are the first-line treatment options for TN, and in around 9 out of 10 cases, these offer meaningful initial pain control. However, the longer you use them for, you may get a diminished return in some people, although for others, they can use them for a very long time and their efficacy remains just as good as the first time they took them. There are occasional contraindications to using these, including things like allergic reactions, obviously, and anyone with cardiac conduction problems. And there's also a high degree of cross-reactivity between carbamazepine, oxcarbazepine, phenytoin, and phenobarbital. If you've got patients who can't tolerate carbamazepine or oxcarbazepine, then lamotrigine can be used, or it can be used as an add-on therapy to increase efficacy as well. One of the plus points about lamotrigine, from my point of view, it is generally associated with fewer side effects than with carbamazepine and oxcarbazepine. Looking at side effects again, pregabalin and gabapentin are less effective, but they do have fewer side effects than carbamazepine and oxcarbazepine, and so they can be used in place of or in addition to these. But do remember that these are controlled drugs in the UK, and there is a risk of dependency, and also they are now street drugs with a street value. Baclofen, especially in people with multiple sclerosis, can also be helpful if you've got someone with TN with multiple sclerosis. And there is also now some evidence that botulinum toxin type A appears to be effective in trigeminal neuralgia, because all trials to date so far do show consistent, significant superiority of botulinum tox type A compared with a placebo. Now, the prognosis of trigeminal neuralgia is mixed, but around half of all people with it do experience remissions lasting at least 6 months. Around 2/3 of people newly diagnosed with TN will unfortunately have a second episode within 5 years, and 77%, about 3/4, within 10 years. Unfortunately, as people with TN get older, periods of remission often tend to get shorter with time, and their attacks of pain get longer. So, I do hope you found that podcast helpful as a quick overview of trigeminal neuralgia, and as I say, we'll be discussing this in our study group meetings starting the 19th and the 21st of March. Do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thank you for listening and goodbye.